All right, so I was fortunate enough to work in a place where we actually have access to almost every hemodynamic support device known, and we participate in clinical trials about it and work with the world leaders in that field. So I'm trying to put this talk, these are my disclosures. So this is the death spiral of cardiogenic shock. And if you notice in the left upper corner here, there is systemic inflammatory response syndrome. So once that happens, basically sometimes the horses are already out of the barn. So how to decide to use hemodynamic support after your efforts in resuscitating the patient, stabilizing blood pressure and cardiac output, what parameters do you use to decide that this patient needs support, or even if they have balloon pump in or some support, do you need to escalate? From the shock trial, we know that the cardiac power output can emerge as the most and the strongest predictor of mortality. So our team also kind of looked into that data, and from the shock trial, we found that 0.53 watts cardiac power output is actually the deflection point when the mortality increased significantly. So the suggestions was, okay, once you heading toward that number, you should think seriously about adding a hemodynamic support. The cardiac power output is calculated by mean arterial pressure times cardiac output divided by 451. And the cardiac power output, the beauty of it, it actually takes the blood pressure and the flow together. So you have a number that kind of tells you the watts, the work of the heart or the cardiovascular system. So our team looked into this, Bobber and Bill looked into this, and they found these parameters. If the patient cardiac power output above 6 and lactate less than 4, and they are starting in shock after 12 to 24 hours, their survival rate was amazing, 96%. That's actually like any other STEMI, the survival rate. If the power output was less than 0.6 and the lactate more than 4, their outcome was very, very, very bad, 30% survival rate only. So it seems to be that the cardiac power output and the lactate level, and from the previous lecture, rightly so, they picked the lactate level to help them pick those patients. So this is the National Cardiogenic Shock Initiative algorithm, Impella, PCI, right heart catheterization. If the cardiac power output less than 0.6, you look for the PAPI. The PAPI is an indication of the right ventricular function. So if there is an RV failure, it could be only RV issue, and you need to go that route. If the PAPI is good, the cardiac power output less, then you need to escalate or add support. If the cardiac power output above 6 and the PAPI is normal above 0.9, then your patient hypotension could be attributed to different things. And from looking at the data, this is basically the golden hour concept. I did an ER. I worked as an ER doctor for about a year before I went to my cardiology fellowship. And I did an ATLS, Advanced Trauma Life Support course, and I learned from it the concept of the golden hour. If you have a patient in a cardiac crash or, car crash or airplane crash, you have only 1 hour to resuscitate them. The mortality increased significantly. This is the red line here is the trauma patient. The mortality increased significantly past that 1 hour. The green line is heart stop. The blue line is respiratory stop. And it seems that the cardiogenic shock mirror massive bleeding. And these are actually the numbers of the cardiogenic shock. And how did we find that out? We found out that delays in mechanical circulatory support is associated with increased mortality. And this is also from our group data. if the patient received the mechanical circulatory support less than 75 minutes, they have much better survival. And those patients who received the mechanical circulatory support seems to be more important than actually the PCI. If you put the mechanical circulatory support before you embarked on doing the PCI, the patient has a better survival. So the non-survival, they have 110 minutes, and survivor has 77 minutes from door to support. So this is an emerging concept, and now it's time of onset of cardiogenic shock. The cardiac shock first is hemodynamic, but if you wait long enough, it's going to be hemometabolic. And once you get to that stage, it becomes really hard to reverse that spiral, and the mortality increases to 71% once you start with the lactate and the GFR and the liver function test. This data, this is the second time I show this slide, is also informative on when it's too late. Sometimes, as some of the panelists pointed out, that you put a wire and you start doing a PCI in a patient, and now this is counted as mortality. So this is also could be a prognostic when you have lactate high and cardiac power output low for more than you need to talk about goals of care. So please do not embark on doing hemodynamic support going it blind. You cannot go blind. You have to use real number. The right heart catheterization helps you distinguish between cardiogenic shock, hypovolemia, and distributive shock, guide subsequent therapy, and guide actually weaning therapy. However, I will caution you, when we first start taking care of those patients, put in mechanical circulatory support, the residents will call me and say, well, the patient now is in septic shock. And it's like after the 10 patient, it dawned on me, he said, they can't be all in septic shock unless like we injected them with bacteria. And I looked back in the literature, and what happens, there is vascular plegia. If the patient in shock, their vessels, they basically convert from low cardiac index to a higher cardiac index because they have vascular plegia. So they actually die. This is study, 45 patients died of cardiogenic shock, 45 of them had actually normal cardiac index. So when the resident wants to start vancomycin and Zosyn, please stop them. These are very, very kind of advanced stage of the cardiogenic shock, and you might be actually too late to salvage them. So unfortunately, the trials so far, there are several problems with the trials. As you know, we cannot randomize the patient that we feel very strongly about support. So this is the balloon pump. Holger-Thiele trial was negative at basically 4 years follow-up. When they compared the IMPRESS and severe shock, compared Impella to balloon pump, it was also not much difference. So, however, despite these trials, we still use mechanical circulatory support. And the reason is because we really seen in practical life, we've seen the outcome. And the registry data, like any other thing, the registry data shows good outcome. So how to use hemodynamic support in cardiogenic shock? In cardiogenic shock, bigger is better. So if you can put the, like, I can't remember, actually Bill told me that nobody wishes that they put less support. So we always need to put the biggest support you can access. You need to know the devices. These are the devices, and there are multiple iterations of these devices. You need to have a full knowledge. You need to have access management, and this is this is a 5.0 Impella from common femoral artery. So far, we've done several cases and actually went really well. ICU management and troubleshooting. This is physician, nurses, perfusionists, right heart catheterization, weaning parameters protocols. These are very, very important because you can't put a cardiogenic shock, hemodynamic support for cardiogenic shock and then hope for the best. We now decided to consult palliative care, not hospice, palliative care for every patient to help us kind of manage expectations with the family. You need a daily assessment, Swan-Ganz catheter, labs, lactate, echo. Hemodynamic support is frequently needed despite negative randomized trial because we see the outcome in real life. Early shock reversal is very, very important, and this is the golden hour concept is actually emerging. Shock management frequently requires a hemodynamic support that should be guided by hemodynamic findings. So this is another kind of plea with everybody. Please go back to the right heart catheterization. The trials that killed right heart catheterization were not done in cardiogenic shock patients. And this is, again, if you need more resources. Thank you so much.